organi- organizational affiliation, director of the World Health Organization Collaborating Center at Trivandrum, the founder chairman of Pallium India. His initiatives to remove regulatory barriers and availability of oral morphine for pain relief have contributed to simplification of narcotic regulations in 17 of India's 29 states and more recently to the amendment of the NDPS Act of India. His initiative has also contributed to the development of a government policy on palliative care in the state of Kerala in 2008 and Government of India's National Palliative Care Strategy in 2012. The international organization Human Rights Watch honored him with Eisen des Forges Award at Los Angeles in November 2014. In 2017, a documentary film titled Hippocratic 18 Experiments in Gently Shaking the World, based on Dr. Rajagopal's contribution to palliative care, was released by Moonshine Agency, Australia. In 2018, Dr. Rajagopal was honored with Padma Shri, the third highest civilian award given annually from Republic of India. In 2022, he published his memoir, Walk with the Weary. Let's welcome him, and I hand over the session to Dr. Sir.
Hello, everybody. Hi. I see a couple of old friends. I see the names of many friends. I would like to see more friends. So even if you are not confident about the current status of makeup, whoever can, please switch on your videos. Virtual education is a problem enough, but having at least a face to talk to. See, the black screens are so depressing. Fill them up, please, with faces and smiles. I see many friends. Mona, Nancy, and Rachel. Okay. Some people must be rushing to the mirror. Anyway, is everybody, is all every participant from within the country? India? Anybody from outside of India? I don't even know how to pronounce your first name. Miss Kennedy, what's the first name? How is it pronounced? And where are you from?
My name is Sinead. I'm from, can you hear me?
Yes, I can.
Yes, my name is Sinead. I'm from Ireland, but living in France.
Oh, hi, Sinead. We have the problem that much of what I am going to say is from the Indian background, but not everything. Human beings are human beings anywhere. We all are born and we die. So some of it would be relevant to everybody. But Ms. Shinia Kennedy, apologies if some of them are a little too Indian. And can I start with a question? How many participants are there? 19. Oh my God. You were talking about dozens of participants. Where are they all? This is the problem in telling them that I'll be here and teaching, and that's why they all ran away. Next time, make it a surprise. Of the 19, 2 are we. So the 17, okay, 17 people there. You could come and to the chat box and answer yes or no. Are you able to think about your own death? Lakshana, now, yes, with difficulty. Lakshana's the image on the screen tells me that she is about 3 years old or 2. Uh, Anamika says no. Many others say yes. So far, can you get a count for me, Sri?
Sure. 9 yes and 1 no. 9 yes and 1 no.
9 yes, 1 no. And the 7 who are missing could well be unable to make up their minds. Very, very likely. Not necessarily, but very likely. That's okay too. Now, to the people, the 9 people who say yes, I would say that you have a strength. Would anybody like to unmute and tell me why I say that it's a strength to be able to acknowledge one's own mortality? I say, I make a claim that when I know that I will die someday, that's a strength. In what way would that be?
Good afternoon, sir. I would like to take a shot at answering.
Lakshana, yes.
Yes, sir. Good afternoon. So I just like to qualify the answer that I gave earlier. I lost my mother in December to cancer, and it was my first, I would say, frontlines experience with someone dying and death. So I think it is a strength. It is a difficult strength to gain, but it is a strength because I don't think anything puts life in clearer perspective than death, and all the priorities that come with living. So yeah, I think it's a very hard thing to do, but I think it's a very useful thing for everyone to have.
Lakshana, December, that means just 5 months.
Yes, sir.
The wound will always be raw, but now it is particularly hurting. I don't know whether you have learned to live with the wounds. Sorry to hear about your loss. And it's not an easy time to listen to this subject now. If you had asked me, Lakshana, should I attend this course now, I would have told you, wait at least for 6 months.
Oh, okay.
Not necessarily not so for everybody. Some of us go into an acceptance and healing very easily. Some of us never heal, though the wound will always be there. But sorry to hear about your loss, Lakshana. Mansi had raised her arm. Mansi, the person who runs Happy Feet Home in Mumbai. Yes, Mansi.
Yes, sir. How are you?
Very good.
So I have been thinking about my death since a very young age. I think, in fact, when I was in my 10th standard, I had actually written 2 pages of more than 2 pages of what should happen after I die and what would I want to do, because I have a very deep belief that I will get an inkling when my time is up, and I want to keep things in order. Like I also have a deep feeling that everyone who comes to our lives, they leave a part of them with us. So I've actually, when I was in my 10th standard, I had written all of this down, and I had written a list of people who I would like to reach out to in case I know I'm going to die, and I would like to write notes of gratitude to those people. And I have done that because I've seen a lot of people die, and I've seen that when death comes, you are gone, but people who are behind you are pretty much left clueless in terms of what you wished, what you wanted, how would you have wanted your last rites to be, and stuff like that. So I think since that young age, I knew that I want to make it clear, and that's why it's been with me.
Thank you for sharing. 15 years.
When I was, this is when I was 16 years old. I'm 42 now.
16. Oh my God. Mansi, possibly you and certainly my generation had the advantage that we lived amidst death. We saw how the cattle die in the shed. We saw how human beings die in the house. We saw how the elders would come in and diagnose death and certify death. The elders in the family, they come and say the limbs are getting cold. Okay, inform everybody. They would say the breathing is okay. Now it's happening. It's a question of minutes. Those things they would say. But now you, all of you and I, are now helping a generation who grow up without seeing death, without confronting death, where death is a stranger. And therefore, death has come to be feared. Death is an enemy. For my generation, death was something that we accepted without question because we saw it around us. We did not have to think about it. Now death is an enemy to be feared. Let me try to answer my own question. Thank you for your responses, Lakshana and Mansi. I think accepting death helps us to value life. Mansi, I don't know whether priorities change for you once you accepted it with difficulty. What is important in life changes. Maybe that dream house with a swimming pool may lose some of its charm. Something that you have not considered important may be valued. And those are things very often which are very meaningful. Secondly, when you accept the inevitability, not only are you able to live life well, you are also able to die well. I'll tell you how. Let me share my screen and share more thoughts with you. This document, the Lancet Commission report on the value of death, was published last year, I think January 2022. And this Lancet Commission report asks us to bring death back into life. Seems a strange word, phrase. Bring death back to life. It was in the lives of Mansi and I, and it's not in the lives of young people who grow up in nuclear families now. And we are saying, bring it back to life. Talk about it. Learn to confront it. Learn to accept it. I would encourage you to read the executive summary at least, if not the whole thing. Give attention to the key messages given there. That will be good preparation for to help the people that we are going to care for. Now, you all know this already. It has been discussed, I am sure, as some part of the discussion. How we respond to a bad situation. Whether it is losing your mobile phone or losing a loved one. No, this cannot be happening to me. Anger, which is against fate or God, and which manifests as you shouting at your children, or shouting at your nursing staff or doctors or social worker. Then you also must be familiar with the bargaining, where you bargain with God, offer 100 candles or something to the temple as a bribe, or you move from modern medicine. Ms. Kennedy, we have plenty of marketing opportunities here. If the doctor says this is not curable, we can go to Ayurveda, homeopathy, Siddha. Next thing, come back, modern medicine, one specialty after another, one hospital after another. Very damaging. Now, having said that, people who are in denial generally cope with life till they are unable to deny anymore, which is in the last few days. Of course, people go into grief or some, and eventually to acceptance majority, but some people get stuck anywhere here. Some people get stuck at denial or anger or bargaining or depression. And our job then is to listen to their stories, listening, and help them to get into a state of acceptance as much as possible. When I said listen, I, more than anything else, would want this opportunity to the person that I am caring for to draw up a chair, sit at a reasonable distance without infringing on the private space, and being there, sometimes waiting till the person is ready to speak. In one of her books, Elizabeth Kubler-Ross, whom you all know, I am sure, who was called the death and dying lady, who wanted to be called the life and living lady. Kubler-Ross describes an experience. She found a child, I don't remember the age, who looked something like 7 or 8, by the roadside, sitting on a ledge. The child's face was so full of suffering that Elizabeth Kubler-Ross went and sat beside the boy. She didn't speak. Great lesson to learn there, ladies and gentlemen. It's so much easier to speak, but she didn't. She just sat there. Several minutes later, the boy raised her head and said, I am planning to run away from home. Did you almost smile? Elizabeth Kubler-Ross still did not speak. She sat there. And then, after a couple of minutes, the boy opened his shirt and showed her chest. On the chest was a scar created by an iron pressing it. It was done by his dad. I'm not sure of the rest of the story. That's not the message. Kubler-Ross's message was about listening, being present, being silent, the value of silence. And very often, I do not have the time to do that. But when I have had the time, I have found it pay huge dividends. Eventually getting to know the person. That body language tells me that she will need several minutes to look up and start speaking. And when she does, I suspect that in the big chance is that she may pour her heart out. And that pouring the heart out will be important for her healing. I stop for a few seconds just to see if there is a hand raised or a question that comes up. I mentioned end-of-life care and the reactions to a bad situation, just to point out that we start here when the person is not dying yet, and this is the best time to start the preparation. As I said earlier, accepting our own mortality helps us to value life and live meaningfully. Help others who are facing death die as well as possible. If we are unable to accept our own mortality, it's harder for us to get somebody else, to help somebody else facing that consequence. I don't know about France, but I know that in the UK, the duty of the healthcare providers defined by law, not in India. In India, your duty and my duty as healthcare providers is defined by a statutory body of the government of India. That's the Bioethics Unit of Indian Council of Medical Research. And this is how they define the duty of care. Here, I would certainly want your input, whether you are able to accept this as the duty of care of you, of the nurse, of the physiotherapist, of the doctor, any healthcare provider. The duty of the healthcare provider is to mitigate suffering. It is to cure sometimes, relieve often, and to comfort always. There exists no exception to this rule. And I need to say this to every medical student and every doctor who would listen. Because today, the healthcare providers see their duty as diagnosing and treating diseases. So when they start learning to think this in this fashion, as defined in 2018, there will be a sea change in my chances of living well until I die and of dying well when my time comes. Unfortunately, in India, this is where we are. Dr. Sankamitra is a British oncologist of Bengali origin who now works in Australia, raising money for charity work in India. He says, in India, the poor die in misery of neglect, the middle class die in misery of ignorance, the rich die in misery on ventilators. No one gets a pain-free and dignified death. No one, maybe an exaggeration, an occasional person snatched away from the healthcare industry into palliative care may die better. But this is the sad state of affairs. Maybe I'll talk a bit more about it later, about the difference between much of the world, at least some of the world, and what happens in India. We see all this. We see all this all around us every day. The poor, the middle class, the rich. If God Almighty appeared before me and said, Rajagopal, I give you a choice. Which of these do you choose? You will have to choose one of these. Guess what I will choose? Anything except the third. The one prayer that I have is that I be not imprisoned when I am dying in an isolated cold room, which is almost like a mortuary, not exactly as cold, but almost as cold, and all alone, hands and feet tied up. Next, please. This is not something that we want to happen. This kind of modern electronic cable covered inhumane death. This is a comparison between Shinat Kennedy's country and India. For example, the first publication that I show on the first panel is a publication in 2019 and from European countries. Please note this point. Where they have more resources, where they could have done more aggressive care, in 90% of the cases, this is concerning people on life support systems in intensive care units. When considered futile, when treatment is considered futile, 90% of them are taken off the ventilator and provided palliative care. 90%. The 10% is understandable. You never know whether really somebody is dying or not. So in 90% of the cases in Miss Kennedy's country, you have a chance of a humane death receiving palliative care. See what happens in our country, ladies and gentlemen. Lakshana spoke. It's only 5 months she had the experience in. I don't want to ask her. But some of you, if there are 19 people here, some of you would have had the experience of loved one dying in an intensive care unit. I am an anesthetist. I was an intensivist. I have lived with this. But when I was in those days, this disease of intensive careopathy was not so advanced. At that time, intensive care was to bring people back to life. At that time, intensive care was not used to send people to the mortuary after cruelty to them. In India, in 70% of cases, they are continued on life support systems till they die. Only 30% are taken away futile, and even then, most of them do not get palliative care. They are taken away in the most inhumane fashion. Sorry to bring in these sad tales, and sorry if I am hurting some of you who live with painful memories in your own families. Anybody wants to comment on this? Lakshana?
Yes, sir. I actually wanted to share that it was having these conversations about dying and end of life care with my mother. I think that's what really helped us actually ensure that she was at home with her family and off unnecessary any treatments or interventions. It helped us actually do that because we read about palliative care, we spoke about these things. So I just wanted to thank you for thinking of my state of mind, but that was actually something that helped us a great deal. So I'm happy to be part of that 30% in India, where we got to make that decision because we spoke about it. Thank you.
Your mother was in an intensive care unit and then was brought out, is that it?
Yes, she was.
And how did you happen to have those conversations? If it's not too painful, painful to rake it up and talk about it.
Not at all. Actually, it's ironic, but I feel like I want to talk about death and dying to everyone I meet right now. So, it was that transformative an experience. So no, my mother had cancer. We found out and we had a very short time between diagnosis and her eventual death. But in the time that we had, I think I'm very fortunate in that we are a family where we decided to talk about it and talk about, what sort of decisions to take at certain junctures in care, at certain junctures in the body's situation. So because we had those conversations, when the time came, we were able to say, this is where my mother would have liked care to stop at the hospital and she would like to go home. And so we were able to do that because while she was still going through treatment, she was able to have this conversation and we were all in agreement. So that was my experience. Sorry.
Lakshmana,
Yes, sir.
Lakshmana,
Yes, sir.
you also realize that you're not everybody. That the
Absolutely. Minority.
the majority of people do not have the courage to talk about it because death is feared. Most people do not want to initiate the conversation. Maybe at some point I would like to learn from you. Where do you live, Lakshmana? Which state are you from?
Sir, I'm in Bangalore.
So most people do not bring it up in during lifetime. It is considered inauspicious.
Yes.
One of my colleagues that my colleagues know, Gina, who is also a writer, she has written an article in the Hindu where she says she was reading Atul Gawande's Being Mortal and just told her mother, Mom, when I die, I don't want this and this. I want that and that. And the mom immediately reacted and said, precisely, exactly, that's what I also would like. And then she walked across to her dad and said, Dad, this and this, not this and this, that and that. And there he was. All the thoughts were there in the mind. We just do not talk about it. So, Lakshana, I see you all know what this means when we fold our hands in greeting and say Namaste. It means I bow to the divine in you. That 2-year-old angel on your screen is lucky to have you as a mother, if that's your daughter.
Actually, no, sir, that is me at 2 years old.
Okay. Just a couple of years back, yes.
Well, thank you.
So, Lakshana, thank you for that comment. Did anybody else want to comment? So, this is a situation, friends, that we all together need to change. Nobody else will change this if we all do not take the initiative and talk about death and as the Lancer Commission report says, bring death back to life. Let us generate death literacy. A generation of death illiterates are around us. We have to create death literacy. His presentation is laid. Let us unmute that. But who do you know that somebody is dying? Well, in 10 to 15% of people, death comes suddenly. Everybody says, oh, wish, I don't want to be bedbound, I want to go. All of a sudden, sorry, very unlikely. Only 10 to 15% people have that privilege. 80 to 85% chance is that you will go through a prolonged illness before you leave. We might as well accept that. So when your majority of your patients are in that state, maybe it'll help the family and help the person. They ask, how long do I have to, doctor? It's easy to say, I don't know. And that's true. We never know. But here is a way of evaluating that, predicting the time, which is only about 80% of being correct if they are in a hospice environment. So understandably, when we move it out to the home setting, the percentages may not work out. Our Sri Priya will make sure that you all have the presentation. I would like you to look at it. This is a busy slide. I don't even want to try to explain it all. But here, see the first and second columns. Palliative performance scale 100% in the first three columns, first three rows. And when it is a person is totally bedbound, it comes down to 10%, provided they are unable to do any activity. If there is extensive disease, they need total care. Their intake is nil and they are only given mouth care. And if they are drowsy or comatose or confused. So various permutations and combinations of these help us to assess PPS, Palliative Performance Scale. So I have a loved one slowly dying at the moment, somebody very dear to me. I find that she is mainly in bed, unable to do most activity, needing assistance, mainly living with assistance. Intake is slightly reduced. She is confused. Her palliative performance scale, therefore, comes to around 40%. And then, once you have that, you go to this prognostication. So, my sister, now in that 40 level, they have a blank for non-cancer patients. We don't know, but is likely to have a few weeks to die. Why do we do that? What's the point? We don't have to do it unless the family very often wants to. They want to know. They want to make plans. You have one child in Dubai and one in California. And then they want to make plans. Okay, they will want to say, one of us wants to be here. And they have their own lives to live. This can be helpful. It can be helpful for us also in helping the family to decide whether they want to live and end in an institution or whether they want to go home. So prognostication is not mandatory, but may be desirable in a lot of situations. You will have to spend some time over working it out because I have quickly rushed through it. I did not really want to go into this in any detail. Next. Okay. Actually, I had the first way when I made the slide, I had asked what would be important for you in the last 1 month of your life. But when I found that some people find it difficult to think about it, I changed it. You can make a guess for me. Most of you are very young. And for me, at my age, it's very easy to think about it. What do you think will be important for me in the last 1 month of my life? That house with a swimming pool? Infinity swimming pool? A Mercedes-Benz? Which will be a liability because my only transportation will be in an ambulance. What will be important for me? Please unmute and speak. No pain. Oh, Ms. Kennedy, absolutely. That is what I will also put first. No physical suffering, minimal physical suffering. As little physical suffering as possible. Zero may not be possible because if I am bedbound, I may have some body aches, which you all will take care of as much as possible. May not be zero. So certainly physical well-being is mandatory, which is what the medical part of end-of-life care will have to achieve. Because if somebody is in intense physical suffering, say for example pain, Pain can be all-encompassing, filling your mind, leaving you no space to give love or to receive love. Nothing else matters. So certainly physical wellness. Seeing people, yes, once I am made physically comfortable, the most important thing that I would want is to be with people who love me, to receive love and to give love. I may want to give a final message to my wife. I may want to apologize for every time I have hurt her. I may want to thank her for all the good things she has done for me. I may want to do that with your children. And once in a way drop in, hey, okay, not whenever possible, come in. I want to see you. That's most important for me. I want to be able to say how much you all mattered to me. To be at peace as much as possible. To live in nature. I will qualify that. In the place that I am comfortable in. Almost all of you have a one side of the bed that you occupy every day, every night. You don't swap sides with your partner. You feel connected to one place. And for most people, that is most important. And please remember that when you pester your mother, oh mom, why are you alone in this village? Please come with me, live with me, I need you. And take her to the apartment in the 34th floor in Mumbai, where on the second day she becomes delirious. So when Mansi says in nature, I will qualify that, where you are connected. It's important for people to feel connected with people, yes. Not bedridden, I wish you that, Mansi, but for most people, 95% of people at least, that won't be possible. How many people have read Tuesdays with Maury? The book by name Tuesdays with Maury. Tuesdays with Maury, Morrie, Mansi has. And Mansi, then you would know that how Maury got peace was when he accepted that he needs care even after passing feces, when somebody else will have to come and wipe him up. Once he accepted that, he could be at peace. Said the last one, being able to communicate. Again, there will come a stage when that may not be possible. We may as well accept that. Mona, send some of that to Pallium India, please. She wants to stop saving money. Utilizing money on myself to reach that more comfortably with dignity. Maybe all those fancy plates that you have in your cupboard, maybe you will bring them out on a weekend and throw yourself a party. Get closure and give closure. Mansi, that's where we will have to help the dying person and the family. Most of them do not get there. Unless we are able to listen to their stories, encourage conversations, most people do not get closure. And it's so very important to be, one of the best things I was remembering among end of life care, one of the best things that I did was to make peace, help the person to make peace with his brother, whom he had not spoken to for 7 years. Some dispute over property, harsh words spoken. I facilitated a conversation. I got his permission and called the brother and said, this is the state of affairs here. He would like to see you. Will you please do me a favor and come? And That memory is so fresh in my mind, like the two brothers then hugging each other, crying together. And
That's
then,
closure, no?
sorry?
That's closure in a way. That's closure for both.
That's part of closure. There will be many areas to be closed. And this for them was one area of bitterness that they would have died with. Amends and living with good, wise lessons for loved ones. Having no regrets. Tanya, we may still have regrets. Unless you are one of those angels with wings. We may have regrets, but it's important to be able to accept that and maybe to talk openly about it whenever possible. I wish, and that conversation is important. Nancy, absolutely, to feel loved and to give love, because that's your biggest legacy. Legacy is so important. And leaving behind that love is so important. Do you know about the window in St. Christopher's Hospice? The first hospice to be built by Dame Cicely Saunders? Some of you may have. Dame Cicely Saunders once treated a Polish Jew who had come during the war. He had no relatives in England. And then he had cancer. Cicely Saunders cared for him. She had a personal relationship with him. And before he died, he said, my earnings, here is my earnings, 500 pounds. I want to be a window in your home. And Cicely Saunders, when she built St. Christopher's Hospice, had a window dedicated to him. People want to leave legacies. And Nancy, by the way, is a psychologist and works with us. Thank you, Nancy. To feel loved and to be able to give love. That's so vitally important, which is what is denied by intensive care units. If Sheetal, thank you. This is what I always wanted to do. I still haven't got around to doing it. And I know if I keep procrastinating, I will end up not doing it. Your bucket list. But at least we can talk about to the person. I may not get around to doing it in time. And then the least you can do is to sit down beside me. Okay, agreed. Listen to me. At that time, I wish. And I had this patient who, this was quite many years back, when these mobile phones were around and everybody had to make calls. She wanted to make an expensive call to her friend in UK because they were connected. They had not spoken in many years. She wanted to ring them up, cry together, and say goodbye. To go back through life, relish memories before dying in peace. Absolutely, Pradeep. Pradeep, it's so important to be able to tell your story. How many of you know where your mother and dad lived as a child and what their early school experiences were? Sit down with them if you don't know and just say, Mom, tell me about your childhood. Tell me a story from your childhood. Dad, continue that conversation. That is so important. And sometimes it gets a bit too late. So, next one. When I tell your story, Nancy, when you are sitting beside me and allowing me to tell my story, I know you will do it because you are the psychologist. Listen to my story without judging. Being non-judgmental is difficult. One doctor who had worked with me for 4 years, when she left us, she told me, of all the lessons that you taught in palliative care, the hardest is not to be judgmental. And I agree. Very difficult. But try to listen to my story without judging. You may be the only one to hear the story, because some of those painful ones, I may not even want to share with my loved ones. In this whole universe, you may be the only person listening to that story. And when I express griefs, regrets, please validate them, acknowledge them. I may be disenfranchised. If you say, but you don't have to think that, that will disenfranchise me. That's what I feel. Acknowledge that. I hear you are feeling very guilty about it. And let me continue the story. And then I myself may feel, may diminish the weight of the guilt. And certainly acknowledge achievements. That's my only chance. And you tell me, hey, at that time, Sripriya, come and acknowledge everything that I have done. Whatever you can think of. That's good. Once I was in Chittaranjan Cancer Institute in Calcutta, doing a teaching session. And the oncologist wanted to bring in a person. They did not have know how to break the diagnosis and the prognosis to him. They did not know how to tell them that his condition was incurable. The man was brought in. It was a worst scenario with 20 people sitting around and listening. But we did that. As soon as the words were complete, the man heard that it was incurable. He started speaking. There was no silence. He was saying, after I retired, I did this. He started talking about the social service activities that he did after retirement from work. He had nothing to say about his work, but then everything, talking about how he taught so many children from poor backgrounds, how we supported families who were starving. He just started talking about it. It's unusual for somebody to talk about that without ever prompting them. But the person was then trying to make sense out of his life. So much of it is left. What did it all mean? What's the point of my life? Why was I alive? And he is trying to find his own answers, and most people do not, and we will have to facilitate that. When he talks about his story, we will say, I really admire how you were the reason for educating 27 children who would have not had their education without you. And that itself will be a great achievement for that person's remaining days. And sometimes they may not want to talk. Be there. And when your whole session, you may spend half an hour with the person without saying another word, but being there and being present is very important. Not looking at the WhatsApp. My time being that person's. Half an hour given to that person completely. Next, please. So, most importantly among these are the things that matter. Tell me which intensive care unit will permit that kiss from a grandchild. So when I am looking after somebody for at the end of life, as you earlier mentioned, totally correctly, it is the most important to be made physically comfortable, treating the pain, but also as comfortable as possible emotionally socially with loved ones, and spiritually, which is what we have been talking about. And when we do that, if we don't do that, without palliative care, when people have to leave, they die in pain and suffering like that picture. The image of the person whom you saw, she did not. She eventually got pain relief in psychosocial suffering, disconnected from their world, without any meaning to existence. Whereas, and the family thereafter have to live with memories of suffering. Lakshana will be able to remember those conversations, the times they have had together, the hugs. Whereas, all too often, when you are allowed only 5 minutes in the morning and 5 minutes in the evening, my colleague, a journalist Sindhu, said, the only thing left to live with are the images of suffering. The father lashing against the restraints and saying, save me, don't torture me, take me home. And the guilt, I wish I had done that. And the broken relationships leave the family distraught. Whereas with palliative care, we can provide physical comfort, retain connections, and sometimes rebuild connections. Life can be made meaningful as much as possible. Give the person an opportunity to leave a legacy, like Cicely Saunders' window, but it may be just a letter that one writes to a grandchild that is not yet born, which is what one of my patients did. And leaving warm memories for Lakshana to live with. Where relationships are still valued and people live with a feeling that they have given their best. So when that's our objective, we remember that the person may be dying, but the person is alive. You are alive till you are dead. And so assume, even if the person is apparently unconscious, assume that he or she can hear and keep communicating. And one of an oncologist, the son of a patient doctor whom he treated, said, whenever I think of the nurse, when my mom was unconscious, whenever the nurse comes and turns her, she would say, Amma, I'm going to turn you. He said, she was unconscious. But the fact that the nurse was giving that respect to the person, with those words, the nurse was acknowledging that you are a person. I am taking a liberty with your body. Please excuse me. And that was so very important. And sometimes people may have some cognition inside and may be unable to express emotions, facial expressions, anything. And certainly the patient is our first focus, but then we will look after the health and emotional needs for carer or the family member. And downstairs in our clinical unit, every time our team evaluates a patient, there is a column for the health situation of the family. Once I was asking this distraught wife of the patient, do you have any health issues? And she said the usual thing, oh, what does it matter? He is so important. His condition is so bad. Leave me alone. I'm okay. Then we found that she was a diabetic and her blood sugar was 420. And she would have been a casualty the next day. So physical health as well as emotional health to the family will have to be looked after. And it is so very important to facilitate religious rites. Unfortunately, hospitals sometimes prevent it. I've seen how a priest, when the patient wanted Holy Communion, and a priest was not allowed to enter the ICU. And that's one of the situations where I ever physically intruded, opened the door, and pushed the priest inside. Parthasarathi Shom lives in North India. He was a bureaucrat and a financial advisor to the Prime Minister Manmohan Singh. After his mother's death, he wrote this article in the Business Standard. Even on the day of passing, a specialist recommended a liver function procedure. When asked if it would end the coma, the answer was the negative. Why that liver function test? We have to ask. This is not, it's only about 10 people here are doctors in the group. A certain number. The doctors here, we need to ask ourselves. Unless it is definitely indicated, why trouble that person with another brick? And what's the point in making the person swallow the multivitamin tablets and the atorvastatin? And certainly we must avoid invasive procedures at that time. Antibiotics are always a question. If somebody is terminally ill and having pneumonia, I would still use antibiotics if they can help to keep the person comfortable. Not only because there is an infection. If it will make the condition better, then I will use it. I'll certainly avoid hospitalization unless essential. Surgery only if needed for pain relief, like even an abdominal surgery may sometimes be necessary because that's the only way to keep the person comfortable. The same holds true for radiation or chemo. Even close to the end of life, a palliative radiation may be necessary to treat bone pain. No feeding tubes unless already in place, and that particularly holds true for dementia. Very unfortunate that elders with dementia are given feeding tubes and then tied up, given restraint and horrors. And dear friends, when you see a child as a caregiver, we need to give particular attention to this. This 10-year-old girl was the officiating mother because the baby in the bed had become living in so much of pain that the mother lost her mind and needed psychiatric treatment. And this girl had completely lost her childhood. The main caregiver, we need to treat them as human beings. Sindhu, my friend and journalist who wrote in the Hindu, says, my 84-year-old father, my best friend, was enduring raw, intrusive medical procedures against his own wish. All skin and bones. He looked defenseless and at the mercy of doctors, his arms tied up, vulnerable and agonized. And we are allowing this to happen all the time around us, even in conditions like advanced dementia and cancer. It shouldn't happen. This document published in The Lancet came out of National Cancer Grid, a conglomerate of more than 300 cancer institutions in the country, headed by Dr. Pramesh, the director of Tata Memorial Center. And they have this guideline, one of 10 guidelines in cancer care. Do not treat patients with advanced metastatic cancer in ICU unless there is an acutely reversible event. You and I know what's happening, including in most of those 300 cancer hospitals. And that happens mostly because there is no alternative, because palliative care is just not available. A question that's inevitably coming up at the end is about euthanasia. Euthanasia is illegal in this country, as it is in France. So we need not discuss it. We don't want to even, I don't want to veer off the discussion of euthanasia. But one thing I know, that withdrawal of artificial life support, legally, no, I won't say legally, there's no law covering it in India. But ethically, it's not euthanasia. If I stop the ventilator when treatment is futile, it is not mercy killing. It is allowing natural. Euthanasia is killing. All good intentions, but it's still killing. Whereas we are only allowing natural death. The term passive euthanasia, which has unfortunately crept into Supreme Court judgments in India, is a misnomer. Euthanasia cannot be passive. And I repeat, ladies and gentlemen, withdrawal of artificial life support in the context of futility of treatment is not euthanasia. It is only allowing natural death. I have prepared my advance directives. A recent Supreme Court judgment earlier this year has validated it. Doctors, according to this judgment, this is binding on you, provided I have put it in writing, which I have. I have named a proxy to take decisions if I am not able to take decisions. And you have a duty to respect my wishes. The judgment says it has to be signed, countersigned by a gazetted officer, which I have done. But if it is a question of withdrawal of life support, there are some problems. In the absence of law, this is what holds legally valid. So as I said, advance directives are valid and the court order permits withdrawal of life support. But they still use the term passive euthanasia, which creates a problem, especially with the church. Catholic Church has objected to this judgment because they believe it permits mercy killing. It is not mercy killing. Moreover, it says 2 3-member boards of doctors have to certify one after the other. And if I am lying there in the ICU, that's too long for me. But then, so that's why my advance directive becomes particularly valid. So friends, if the question comes up, is it legal to withdraw artificial life support in our country? There are 2 answers. One, all this becomes valid only when there is an issue. If I have expressed my wishes, and if the family is with me, the doctors agreed, the legal question doesn't arise. You can just stop the ventilation. But if there is a legal issue, then we talk about it. But we all, social workers, psychologists, doctors, nurses, we all will remember that our duty of care is to mitigate suffering. And there exists no exception to this rule. I would strongly recommend, irrespective of the age, everybody prepares an advance directive. Get it countersigned by a gazetted officer. Sorry, I'll have to make that other correction. Gazetted officer. Keep a copy of the medical records along with your last lipid profile or whatever. Keep a copy of this also. And more than preparing the advance directive, much more important, talk to the family about it. Make sure that they understand it. Even if you have created a legally binding document, if my son objects, no sensible doctor will follow my instruction. because they know dead people do not go to court. Living relatives go to court. That Lancet Commission report recommends that management of suffering should sit alongside extension of life as a goal of all healthcare. That education on death, dying, and end-of-life care should be in the curriculum of every health and social care student and in continuing education for practicing professionals. That patients and families should be provided with clear information about the uncertainties as well as the potential benefits, risks, and harms of interventions in potentially life-limiting illness to enable more informed decisions. I don't know how the doctors feel about it. Everybody will blame somebody else. They will say the families always insist on that. The whole society doesn't accept this. Legal law doesn't allow us. Personally, I think the biggest problem is that doctors often feel that they have a duty to preserve life at all costs. And to them, life is defined as a beating heart. But all these are problems, I understand. And to overcome them, we need advocacy. The 21 people listening to this, I hope, will all appoint themselves as advocates for the dying to make sure that we speak about it, we write about it, we encourage discussions about it. So at some point during the course, I hope you will talk about a sustained concerted effort with media partners and have some strategic planning with times and deliverables about an action plan for bringing death back to life, for creating a death literate society. Thank you, ladies and gentlemen. I see that we have 15 minutes at least for discussion. Asking for unmuting and speaking your chat.
Everyone, you can put your any questions, you can put it in the chat or unmute yourself and ask the question if you have any doubt.
Or a comment, or a suggestion.
Anything as well.
We should give a couple of seconds.
Yes. Respect the silence.
Actually, sir, I have a question.
Yakshana?
Yes, sir. So my question, I'm not a medical professional. As I may have mentioned earlier, I feel like after my mother's death, I want to talk about death and dying. I hope more people will learn about this whole thing, because this whole set of sessions has been very informational, educational, and I want to talk about it. Where would you recommend starting something like this as somebody who is not a medical or a trained, psychological support sort of person?
Yakshana, many things. Like I already, during my talk, I told you about 2 articles. Tina and Sindhu, neither is a medical person. One is an engineer and a writer, the other is a journalist.
Right.
Their writings matter. How many thousands of people would have read them? And giving visibility to that is so important. Through what you will write, you will create more awareness. But that's what you can do as an individual. But what we can do as a group is having a consistent program, public advocacy program. They say if you hear something or if you read something in the newspaper or on your Facebook post, the next day you forget it. Whereas if something enters your consciousness at a regular interval repeatedly, sticks there. So maybe we can all have a concerted advocacy program. Even yesterday, I was talking to Devi from Calcutta, Devi Vijay, who attended one of the Arohan programs here. And she is also thinking in these lines. So, Lakshana, what do you think about having a concerted advocacy program to bring in that literacy? And you writing your story will be very valuable. Short things. Maybe you will create a video, just 1.5 minutes. Anything 7 minutes, no, nobody today views it, but something with your main message or several videos, self-made on your mobile, 1.5 minutes each or 2 minutes at the most. Those things are very important. That's my feeling. But let us hear from the others.
Thank you.
Okay, sorry. No. When Lakshana may want to think about it and respond more, in the meantime, Tanya, dying with dignity is what I want, is what most people want. We want to go with some dignity. And to healthcare professionals, sometimes we forget to draw the curtain. Dignity may also be in those little things, like closing the door before doing a procedure, before undressing the patient, but also about valuing the person as an individual. So that's what the dying with dignity is called. But in USA, they gave that term to something else, unfortunately. And anything in the USA is very visible and prominent. When they created a law in some states legalizing mercy killing, assisted suicide, they called Death with Dignity Acts. So in USA, and anybody who is following USA, Death with Dignity has now come to mean assisted suicide or euthanasia. That's not what the term means. So, Tanya, there is a risk. If you talk about death with dignity or dying with dignity, which is what we all would like, you may be misunderstood as promoting euthanasia.
Thank you so much, sir.
Mona says, we don't need to ask my dad. He always speaks his childhood story to the grandson, like in films. Yes. Okay. Nimsi,
Yes, sir.
comments from you.
Comments from me is that as I listened to the session, I kept wondering of my father and mother, and I'm heavily dependent on them. So thinking about death, their death scares me more than thinking about my death. But speaking about death in a very healthy manner, and like you said, to get them decide on okay how they'd like to die, getting those details. So all that becomes very important, and more than that, for all of us to be aware of this, because one of my relatives, he was diagnosed with cancer, and he also had a very terrible death in the ventilator. And over there, the family members were reluctant to withdraw the support, and we couldn't pressurize them beyond a certain point. And I was just having all those thoughts cross one after the other. And now, because I come to Parliament here regularly, I get to see a lot of patients, and to be able to hold their hands and show compassion, that helps me position myself in a better way. So Thank you. Thank you for this wonderful session. And I also thank the participants who are there in the session, because they, when they share their personal stories, I get to learn from them as well. So thank you.
Nancy, thank you. About your first point, that's a very important point. Nancy, I would like to talk to you about it later.
Yes, sir.
About 6 years back, I was asked to see a young, middle-aged man. His parents, his father is a scientist in Space Research Organization. He is the author of scientific books, a very senior official, reasonably well-to-do family. So they did not really need my help to look after the middle-aged man, their son. These couple who are in their 80s wanted me to see the boy to bring up something. They are in their 80s. The same question that Nancy mentioned. What will happen to them? What will happen to him if one of us dies? Because one of us alone cannot care for him. 6 years back, I gave them this promise that if at some point they are unable to look after him, we will be there for him. That we will take the responsibility to make sure that he is cared for. And after one social connection in between, the gentleman connected with us again 3 days back. They are now more worried. They are getting older. The man is getting to be more difficult. We kept our promise. So what are we going to do? We are going to find the best possible place for where he will be cared for, with we providing visits to him. But if that doesn't work out, we also have the alternative of admitting the man to our place and looking after him till we find a better place for him. Now, Nancy mentioned this problem of elderly people worried about offspring who are dependent on them. It is important to bring those thoughts out. It's important to create solutions. This is what we will do. If it comes to that, this is the solution. Vitally important. But then let me also mention something else. So this kind of thing very often happens in end-of-life care. The offspring needing the elders, how emotionally dependent on them, physically dependent on them. That's very real. And it's in a way, it's a selfish kind of love. I can't let him go. I need him. And the result is they may be put on a ventilator forever. So at some point of time, we will have to think about how much they are suffering also, and then balancing those two thoughts. Mona, would you like to read it out yourself? I don't think I heard your voice today. Please unmute.
Many times, patient and family feel some kind of negligence on part of doctors on account of rude behavior and ignoring patient's pain. But they can't do anything just because complaints and medical council usually ignore caregivers' complaint. Who will fight for those patients and caregivers? Then I said palliative care should involve patients' right along with doctor's duty.
Mona, so totally true. Not only about patients in that situation and doctors, but in our country, which is described as the one with the, Arundhati Roy called it, vulgar disparity of life around us. It is the people with power disempowering the voiceless. The doctor and the hospital holds all the power. the patient is disempowered, stripped of all rights. And where there is power, it may get abused. You have a big question, which is to be taken at another level. But what can you and I do? When they have the stories, they never forgive. The people who have been insulted at that time of vulnerability never forgive. They live with the bitterness. I once had a young man who died, one of two twin brothers who died. And the surviving twin came back a week after the man died and said, "How are you? I am managing okay. I came to tell you something. I am living with the intense desire to murder one person. I feel like stabbing the doctor who was cruel with his words to my brother." Then he said, No, I'm not going to do it. I know I will not do it. I wanted to tell you that this is what I feel like. So when there is rude behavior, when people are very vulnerable, they are not forgiven. What I needed to do at that time was to spend half an hour with that man. He thrice repeated the story of the insult. And I was a listener. And at the end, I apologized to him on behalf of the whole medical profession. That's all I did. I did not raise war. I do not dare to raise my voice against all the injustice in the world. What I do, I believe, should be calculated and without raising so much of animosity from the healthcare industry that I will not be able to function. I shouldn't be a Don Quixote fighting the windmill. I should pick my battles, plan the strategy, and then do what I can, one thing at a time. So, Mona, it is sad, the injustices that are happening. But we can be there for the person insulted. Hold their hands, wipe a tear, and then think about what we can do against the injustice. One of the things that we may end up to doing as a team, again, is more visibility to the problem. Like describing the story, maybe without identifying the person, on a newspaper story, on a social media. Those things matter.
Anyone else have any more doubts? So, okay.
Time is up.
Okay. Time is up. We are concluding this session. Thank you all for participating in this session. Thank you very much.
Thank you everyone for joining in. Personally, the first session on end of life care after joining Pallium India has been a beginning for me. Even though the session is titled that, it was definitely a beginning for me with thoughts about what could be done. And I believe that everyone in this session would also feel the same. Yes, Lakshana, it is definitely an honor to have Sir addressing us, because he's such a busy person that we seldom get his presence nowadays. And we do believe that the journey of 1,000 miles starts with a single step, and believe that this was the single step in your lives. So with that positive note, this is Sri Priya, along with Dr. Emma Rajagopal, the stalwart of palliative medicine in India, and Ms. Preeti, signing off from the Tipseco Hub. Sir, thank you so much for joining us, and we wish to have you in such more sessions.
Thank you.
Thank you, everyone. Take care. Bye-bye.
Have a great evening.